Good morning, all. Today's topic of discussion is osteoradionecrosis. Osteo means bone and necrosis means death of cell in organ or tissue due to disease, and it causes failure of blood supply. It is also known as radiation osteomyelitis. It is one of the most serious late complication of therapeutic radiotherapy if the radiation is more than 16 grade. Radiation causes mucositis, atrophic mucosa, xerostomia. Radiation carries pain, bone loss, and cosmetic disability. The definition is osteoradionecrosis is a radiation-induced non-healing wound of irradiated bone which fails to heal without intervention. According to Marx, it is a chronic non-healing wound caused by hypocellularity, hypovascularity, and hypoxia. And according to Marx, it is classified into type 1, type 2, and type 3. Type 1 develops shortly after radiation due to synergistic effect of surgical trauma and radiation injury. Type 2 develops years after radiation and follows a trauma, rarely occur before 2 years of treatment, and commonly occur after 6 years due to the progressive endarthritis and vascular effusion. Type 3 develops spontaneously within 6 months to 3 years after radiation without a preceding traumatic event due to cellular damage and death caused by radiation treatment. Then triad of osteoradionecrosis. According to Myers in 1971, the three triad of osteoradionecrosis is radiation, trauma, and infection. With pathophysiology, radiation causes irreversible cell change and dysfunction, which causes vascular damage and leads to endarthritis and thrombosis of vessel, which can cause hypovascularity and gradually ischemia, which leads to hypoxia. It also causes damage to other bone tissue components and causes loss of reparative and synthetic function, and that can lead to osteoradionecrosis. And it also causes bone tissue cell death from direct irradiation damage, which leads to hypocellularity, and that causes tissue breakdown, and also that can also lead to osteoradionecrosis. And the clinical features of osteoradionecrosis is severe penetrating pain, swelling of face, fetid breath, trismus, exposed bone associated with intraoral or extraoral fistula, pathologic fracture, and pyrexia. In the radiographic features, it usually appears as radiolucent with indefinite non-sclerotic border and occasionally area of radio opacity, which is associated with bony sequestra. Sequestra and involucra occur late or not at all. Then, for investigation, blood flow assay with nuclear isotope technetium-90 and methylene bisphosphonate scanning is used to assess the regional perfusion of afflicted areas. We can also do culture of affected bone and show only surface organism, Streptococcus candida, Streptococcus gram-negative organism. If skin is affected, Streptococcus aureus and Streptococcus epidermis is the cause. And the differential diagnosis include calcified ground, odontoma, periapical abscess, periapical granuloma, and condensate osteitis. And management, conservative treatment include systemic antibiotics, analgesics, selective rinsing with topical and antiseptics. If sequestra is present, selective removal can be done, curettage and local debridement can be done, or burning it out until normal bleed bone appears. Abscess or cutaneous fistula, if present, should be sent for culture. Then ultrasound therapy with local debridement is another management. And if patient is having toxicity or dehydration, then hospitalization is done and IV antibiotics and fluid, usually penicillin plus metronidazole or clindamycin can be given. And other supportive measures include hydration of the patient, fluid therapy, or high protein and vitamin diet. In surgery, sequestrectomy, excision of necrotic end of both fragments and replacement with a large graft, nerve avulsion, rhizotomy, and bone resection can be done. Then another one important management is hyperbaric oxygen therapy. Then some new option, that is pentoxifylline and tocopherol combination can be used. Then good oral hygiene should be maintained. So oral rinses such as 1% of sodium fluoride gel, 1% of chlorhexidine gluconate, and plain water help to prevent radiation-induced caries from the xerostomia and mucositis. The use of hyperbaric oxygen therapy is it inhibits bacterial toxin formation, enhances killing ability of leukocytes, stimulates fibroblast growth and increase collagen formation, and promote growth of capillaries. This hyperbaric oxygen therapy consists of breathing of 100% of oxygen through a face mask or a hood in a monophase or large chamber at 2.4 atmospheric pressure for 90 minutes section or dives for 5 days a week, totaling of 30 dives or more section followed by another 10 dives or more section. According to Mark's Miami protocol, stage 1 is exposed wound with non-healing wound. 30 hyperbaric oxygen therapy is given and then review. Those responded well, then extra 10 dives is given. In stage 1, non-respondent then it is considered as stage 2 or osteoradionecrosis. In stage 2, local debridement is done to induce fresh bleeding, followed by 10 hyperbaric oxygen therapy. In stage 3, non-respondent stage 2 osteoradionecrosis, or those patients with cutaneous fistula, pathologic fracture, or inferior border resorption, surgical resection is done with stabilization of the remaining jaw by external fixation or intermaxillary fixation. Then further 10 HBO. In stage 3R, if reconstruction is required, then they enter stage 3R. Reconstruction with a free bone graft is done only after 3 months. Then complication, oxygen toxicity, seizure, high pressure nervous syndrome, decompression symptoms, pneumothorax, arterial gas embolism, tooth and sinus pain, visual changes, gastric distress. Contraindication, absolute contraindication and relative contraindication. Absolute contraindication include optic neuritis, immunosuppressive disorder, relative chronic obstructive pulmonary disease, and claustrophobia. The current trend in the management of osteoradionecrosis is pentaclo protocol. It is first phase for 4 to 6 weeks, 2 grams of augmentin, 1 gram of ciprofloxacin, and 50 milligram of fluconazole plus 20 milligram of prednisolone plus 20 milligram of omeprazole. Second phase, 800 milligram of pentoxifylline, 1000 international unit of tocopherol plus 1600 unit of clodronate. Then prevention of osteoradionecrosis, pre-radiation dental care, that is extraction of teeth 2 weeks prior to radiation. Then if prominent interdental septate sharp socket margin, then it should be trimmed and remodeled. Resorption of alveolar process will not occur after irradiation. Unerupted and deeply buried teeth should be left in situ. Then restoration of teeth should be done. Post-irradiation dental care. The denture should not be worn in the irradiated jaw for 1 year after therapy. Maintenance of oral hygiene. Application of topical fluoride as for the pre-irradiation care. Saliva substitute. Post-irradiation pulpitis, endoscope, endo, endodontic therapy, if preferable, can be done. Excision should be limited to one or more teeth and the antibiotic therapy. Antibiotic therapy includes 2 grams of penicillin B plus 500 milligrams of metronidazole orally 1 hour before the surgery and 500 milligrams of both 4 times a day for 1 week after extraction, or can you give 600 milligram of clindamycin 1 hour before surgery and 300 milligram 3 times a day for a week. Thank you.